weight bias in diabetes care. And for that talk, the speaker is a very well-known person to all of us, Dr. Jayant Panda. He is a fellow Diabetes India, consultant diabetes, metabolic and critical care medicine, professor of PG Department Internal Medicine, SCB Medical College. He has a lot of, he is a chairman Aero, member executive committee Aero, lot of post, very famous. So, sir, over to you for the talk.
Thank you, ma'am. Good afternoon, everyone. And I thank the team JPEF 25 for this nice program and the invitation. And my topic is to doctors carry weight bias in diabetes care. Exploring stigma, impact and its solution. We have less delegates over here, but I'd like to know, in your practice, a obese patient and a lean patient, when you come across, maybe in diabetes or any other field, you carry some bias or no? Anybody who carries a bias, please raise your hand. I don't think any of you, they have a bias. But what happens in the society, you know, if somebody is obese, fat, and he's completely differentiated from the rest of the mass. In the North India and many parts of the country, people start calling him mota, a fatty person, and as usual, listening all these descriptions, the person becomes very irritated and loses interest in the consultation or anything. But that particular feeling should not be there in doctor's mind is what is the theme of my talk. And I'll tell how it is placed in the society and how we should go about. First, I must thank my friend Jyotidev Kashabadev, who has not only hosted this very regularly, but taken you all through best of the science every year for last 13 years and made all of us wise. JPEF 25 had done a marvelous job. You are seeing the contents, seeing the discussions. The weight bias leads to unfair treatment of patients with obesity, affecting communication, diagnosis, and overall care quality. Here, there are two words. One is bias, one is prejudice. Bias is an unconscious tendency. Prejudice is a conscious negative judgment. Both can affect the patient care, and both examples are there in the society. Why this matters in diabetes management? Because bias can harm the trust, reduce adherence, and worsen diabetes outcome due to a missed or delayed care. Weight stigma is there with everyone in the society. It refers to a negative attitude, stereotypes, and discrimination directed at individuals because of their weight, often leading to shame and social exclusion. There are two types of bias. One is the implicit and one is explicit. And you know, implicit is an unconscious belief or attitude. You never want to hurt your obese people, but once they have come, they are differentiated from the rest because they look different. They need more space to move, they need more space to sit down. And this unconscious belief or attitude which influence our behavior towards people with obesity, even when we are unaware of them, is implicit bias. Broader term encompassing both implicit and explicit prejudice towards the people with excess weight, often resulting in unequal treatment, especially in healthcare, is designated as weight bias, and we'll see how common is this amongst the doctors. We know the obesity rates are rising worldwide. It's becoming a major public health crisis that increases the burden of chronic disease. And rising diabetes prevalence, type 2 diabetes is going to touch 600 million worldwide. So closely linked it with obesity. Type 2 diabetes very commonly seen in obese people, and the common risk factor is insulin resistance. And both conditions are increasingly together, especially in developing nations. And the bias affects care outcomes because it can lead to misdiagnosis, poor communication, unequal treatment, directly impacting diabetes management and outcome. Once you are here, you will feel that your person must have insulin resistance, which is not truth. How bias develops? The societal stereotypes. People with obesity are often unfairly labeled as lazy, lacking willpower, which influences healthcare attitudes. So when we see a obese person, we presume that he or she must not be doing exercise. The media portrayal of obesity, the media often reinforces negative images, showing obesity as a personal failure rather than complex health issue. In the movies, in the serials, and all communications, you see this has been stigmatized. So now World Authority cautions not to make any comment regarding the weight or target the person. The gaps in obesity education, the many healthcare providers lack formal training on obesity as a chronic disease, leading to biased care. Even the medical students are not given that approach. So this carries this attitude. The explicit, I have told, is a conscious bias, open, intentional, negative attitude or judgment about people with obesity. Many obese people tell we are being judged by our friends, by our teachers, by our doctor, in the school, in the office, in the home. And implicit is an automatic, unintentional belief that will influence behavior without awareness. You must not be that virulent towards them, but you may have little feeling. So there is a structural bias, that is systemic practices or policies that disadvantage people with obesity across the healthcare setting. The evidence in healthcare, the providers spend less time with obese patients. Studies show shorter consultation reflecting reduced engagement or patience. So when you see your patient is more than his normal weight, you presume that he must have all metabolic problems and you conclude your clinical decision early. There is lower empathy, poor communication. Obese patients often receive less compassionate and respectful communication, and there is delayed diagnosis as well, because symptoms may be wrongly attributed to weight, leading to later misdiagnosis. The study from by Paul and Here in 2010 shows 69% of healthcare providers acknowledged having weight bias. They are not only doctors, they are paramedical workers as well, and less preventive care because of the obese patient are less likely to receive screenings and the early interventions. More bias in chronic care because of specialties managing long-term illness like diabetes show higher levels of weight bias. So the bias in diabetes care includes diabetes, often blamed on lifestyle. Doctors may overlook genetic and metabolic factors. Many times we think that because of poor lifestyle only, the person is gaining weight, focusing only on the behavior. The assumptions of non-adherence come. Patients with obesity are often unfairly seen as non-compliant with the treatment and lack of individualized care. The care plans may be generic but not tailored to the patient's real needs and challenges. If you spend more time with your patient, you detect and you point the target where you should intervene. And the impact on the patient trust is patient feel judged. If many feel shamed during the consultation due to weight-related comments or tone, patient feels judged. And avoiding medical visits for the stigma leads to patient delay, they skip important healthcare appointments. So doctor के पास जब जाना होता है, when there is occasion to meet the doctor, the patient thinks I'll be judged, I'll not be given due time. The doctor again will tell me to lose weight. Why should I go? The erosion of trust. Negative experience reduces trust in doctors, affecting long-term care relationship. The psychological impact is tremendous. There is depression, anxiety, weight-related stigma can worsen emotional distress, leading to mood disorders. Reduced self-esteem, constant judgment affecting how patients view themselves, lowering self-worth, and the disordered eating stigma can cause unhealthy eating patterns like binge eating or food restriction. To overcome the depression, anxiety, usually people overeat. The clinical outcome is poor glycemic control. Stigma and stress can interfere with consistent diabetes self-management. Non-adherence to the medications, feeling judged, may cause patients to skip or stop medications, and higher A1C due to stigma. The negative experience linked to the worse blood sugar outcome over time. So implicit association test is there. This is a IAT which detect the bias. It measures the hidden bias. Tools like implicit association test reveal the unconscious weight bias by the healthcare personnel. Strong anti-fat bias in providers. Studies show many healthcare professionals hold negative views about obesity. Need for introspection is recognizing personal bias, the first step towards the delivering fair, respectful care. The manifestation of bias is microaggression, where subtle comments or actions that convey disrespect towards the patient with obesity. And the tone, assumptions, you get negative tone or assumption of poor lifestyle choice with alienate patients, and the clinical signs like important symptoms may be overlooked, blamed solely on the weight. Type 1, usually they get sympathy. You saw in our Perrier Hall, the session started with type 1, and they get sympathy because less stigma, because often viewed as non-preventable, and patients face less blame. But type 2 blamed on lifestyle. Type 2 frequently linked to personal choices, leading to more judgment. And if the person is obese, he will be criticized, may it be the parents, may it be the friends, or may it be the treating doctor. Need equal empathy. Both type require understanding, not blame, for effective care and support, because many suffer because of their gene, because of their metabolic constitution, not because of eating. Really, they don't eat much. There is a barrier to neutral care, lack of training. Many providers are not taught to manage obesity as a complex chronic disease, and weight as a sole metric. Care often focuses only on BMI, ignoring overall health and behavior. Ignoring social determinants, factors like income, environment, stress are often overlooked in the obesity care. Medical education gaps. The minimal obesity science, the medical education rarely covers the biology and complexity of obesity in depth, and students are not taught properly. Focus on discipline over compassion, as training often emphasizes willpower, not empathy or patient-centered care. There is poor understanding or chronic nature. This obesity is often seen as a temporary condition, not a lifelong disease requiring long-term management. And you will not be surprised to know, till recently, the regulatory authorities never accepted obesity as a disease, as a chronic disease, which is mother of all non-communicable metabolic illness. So decision-making impact is there, and then the diagnostic overshadowing, the health issues blamed on the weight, leading to missed or the incorrect diagnosis. Avoiding advanced testing. Doctor may skip needed tests, assuming symptoms are weight-related. When somebody comes with osteoarthritis, we think of the obesity, and the osteoarthritis is the result. We never even go for an X-ray to see what stage it's there, or is there a local pathology. There are altered referrals, like they may be less likely to be referred to specialist and advanced care, because many take it for granted that their disease is related to the weight. There is a bias in language. We tell morbidly obese. There are very few of us who write person with obesity, person with diabetes. This is a proper term and then not stigmatizing. We write morbidly obese. We write the people are grade 3 obese or like that. So there should be respectful terms reducing the bias, and the blame center words, the language that blames patient for their weight, can harm trust and motivation, and we can never control weight in those people. And people first language needed, putting the person before the condition, promoting dignity and compassionate care. So make it a point to diagnose the person with obesity then morbidly obese next time you see a patient. Implicit and explicit, I have already told. The unconscious, the automatic hidden bias are implicit, influencing behavior without awareness, and explicit is conscious, deliberate, negative belief or attitude towards people with obesity and need dual intervention. Both type bias should be addressed, though explicit hurts more. Implicit, you never know, but it comes to your mind, training and system level change. There is gender and ethnic disparities. The women face more bias. If a lady is obese, women with obesity experience greater judgment and discrimination in healthcare at the family, at the friends level, the society level, and in even medical institutions. Certain ethnicities affected more, like racial and ethnic minorities with obese often face the compounded stigma and limited access to care. The intersectionary matters, that the overlapping identities like gender, race and weight can intensify bias and worsen health outcomes. The technology and EMRs, even if you don't do anything, your electronic medical record and your AI system detect the person obese by BMI based flags. And then they highlight BMI, reinforcing weight as the primary concern over overall health. And then certain stigmatizing note are put by the EMRs, influencing future care. So AI tool replicating bias, the algorithm trained on the bias data can unintentionally reinforce weight-based discrimination in clinical decisions, because they are designed like that, they point to the weight. There is media influence. I have already told the unrealistic body standards, like media promoting narrow ideals, fueling negative perceptions of people with obesity. Blame in health journalism, like articles often oversimplify obesity, framing it as personal failure rather than a complex issue. And public health needs, there is a new tone. Message should focus on health and inclusion, not shame or fear-based tactics. The bias in the allied healthcare, like present in the nurses, dietitians as well, not only doctors, it affects care and coordination. Whole team needs awareness. The all healthcare professionals must change their view to the obese people, show their sympathy, be open to detect the cause, and controlling their food and weight as far as practicable. The patient narratives, the stories of bias often share experience of being shamed or dismissed due to their weight in the healthcare settings. And the survey data also shows, the research consistently showing many patients with obesity report feeling judged or mistreated by the providers. The quotes showing emotional toll. The patient quotes reveal the deep emotional impact, weight stigma, including feeling of embarrassment, guilt and isolation. Usually they are emotional people, and these comments make them more emotional. There is a cost bias also. If we diagnose late, the higher cost from delayed care comes and complications rise, and there is a quality adjusted life years decrease, a stigma negatively affecting physical and mental health outcomes. Ethical concerns violating medical ethics, justice and fairness issues, and anti-bias policies, they come into picture. And overcoming bias by self-assessment tools, bias training programs and CME credits are required by the physician. The communication strategies like motivational interviewing, empathy, focused talks, avoiding judgmental tone are very important. And in our country, the stigma and bias are more than Western countries, where an average person is obese or overweight. If you go to US, they never tell a person that you are obese or you are overweight, because all are of that standard only. I tell it American standard. So people first language like person with obesity should be used, avoiding labels like obese or fat, and shifting health focus terms, and the HIES model, which is the health habits like activity, nutrition, regardless of weight change, weight neutral care and improved long-term outcomes, policy interventions. Diabetes societies like ADA, ASD, RSSDI, they have to bring it to their guidelines and policies. The cultural competence respecting patient context, family, personalized approach should come, and patient-centered care, designing respectful communication and empowerment over discipline should come. There should be teaching empathy and role play in the training and narrative medication tools. All research gap with long-term data, scare Indian context studies and more localized research should be included. So finally concluding, recognizing and reflecting the bias, acknowledging the personal bias, educating peers, sharing knowledge, and promoting inclusive care, adopting respectful language is important. So ladies and gentlemen, we have to be careful in our words and approach to the people who are obese. And now you know that obesity has been designed as a disease and can be intervened very effectively. We have to assure our patients, I am there with you in weight loss and you can be as smart as you have dreamed. Now let us have that habit and take away the bias which is highest among the Indian healthcare professionals. We welcome you to Odisha. Tomorrow and day after we have Metabolic Horizon. Next week we have Clinical Cardiodiabetes Society of India conference, and in August we have 13th annual conference of RSSDI, and I invite all of you to these academic events with beautiful land of Odisha and land of Lord Jagannath. I thank again for the opportunity and your timing, and I'll be happy to take up questions if any.
Thank you, sir, for that